Hello and welcome to the lecture on the equation of motion. So I'll try to keep it as brief as I can. There's going to be lots of pictures in here because this is not an easy subject to talk about. And when we're looking at the equation of motion in mechanical ventilation, this is pretty much how we're helping the patient take the workload away from them so they can breathe easier. And it can also tell us between the two variables, the primary variables that's going on with the patient, which one do we need to focus on. When we're looking at the equation of motion, we're looking at how much resistance there is to gas flowing in, and then how easy it is for the lungs to stretch. And if either of those or both of those are wrong, then it's going to make the patient work harder to breathe. They're going to use more accessory muscles. They're going to stress to breathe. So when you walk into a patient's room and you see them working really hard to pull a breath in or to force a breath out, then that's going to tell us that they're working hard. And that's the equation of motion. How do we take that work of breathing away from the patient so they don't go into respiratory fatigue or respiratory failure? And if they're in respiratory failure, what can we do to adjust our settings to help that patient, or interventions to help that patient? When we're looking at this, the big thing is to remember the muscles that the patients are using to breathe are usually skeletal muscle, and that skeletal muscle is going to be a big chance to fatigue for these patients. So all the muscles that are used to generate inspiratory efforts and the muscles generate to do expiratory efforts can be involved in this if a patient's working hard. The other thing we think about is what could cause resistance to the breath going in, what can cause issues with the compliance, not letting the lungs stretch, right? Or an increase in elastance, which is the lungs snapping back. So we're going to look at all of these together, and we'll look at how we can help these patients all together. So it states the force that we need to drive ventilation. And so that's what we're looking at here. Ultimately, if you're a nerd like me, it's the application of Newton's third law of motion. But let's break it down. So simply stated, put into words, the equation of motion states that the force utilized to drive the ventilation by the respiratory muscles or the ventilator is equal to the force applied by the respiratory system in the opposite direction. In its purest sense, this equation is an application of Newton's third law, as I said earlier. So when you're looking at this picture, you're going to see some of the issues here where we have pushing the ventilator breath into the patient. We have to oppose the elasticity of the lungs, and that's what's going on with these springs right here. These springs saying, hey, it's harder to stretch, right? To push a spring out, or just like a rubber band, to pull it, to get it to stretch out. And that elastance is saying, hey, I want to close. I want to keep it in its resting state. And so it's opposing that breath delivery. So the more elastic, the stronger your springs are, which can happen with things like pneumonia, with pulmonary edema, fibrosis, and sometimes this is a chest wall abdomen thing. If there's fluid in the abdomen, anything like that, then that's going to push and resist that breath going in. So we're going to have that low compliance. So that's going to make for more workload for the patient to breathe. And then you're also going to see these springs on the outside of the chest, right? The chest wall recoil springs. The chest wall, back in pulmonary anatomy and physiology, naturally wants to expand. The rib cage wants to stay open. The lungs want to stay closed, and it creates this push-pull relationship between the two, where the rib cage wants to be expanding and the lungs want to be collapsing, and that creates that negative pleural pressure that we see there. But ultimately, these are the forces that we have to overcome to expand the lungs, not only the elasticity of the tissue, but also the resistance of the gas flowing in as well. So we have this viscous resistance, is the fancy word, to oppose breath delivery. So let's start with the left side of the equation. This side describes the total pressure required to generate a certain level of ventilation. So to have adequate ventilation over here on this left side of the equation, we either need to use our muscles or our vent to help get the patient to breathe adequately, to exchange gas, to get rid of their CO2, to get oxygen into their bloodstream. So if a patient's working hard, their muscles, PMUS here, if they're working hard, then we need to take that workload away from the patient, whether it's resolving the underlying issue with them or using a ventilator, whether it's invasive or non-invasive, to take that workload away from those muscles. So this equation is really the summing up of what's going on with your resistance to the gas going in, as well as how hard it is to stretch the lungs, right? How elastic that tissue is. So that's what we're looking at here. And when we have a patient that's working hard to breathe, it's one of two things, or it's two of two things. It could be their airways, their large conducting zone airways, like a vocal cord dysfunction or a bronchospasm. All those large conducting zone airways are creating a lot of resistance to gas flowing in. Think about you trying to drink a milkshake with a coffee straw, right? There's a lot of resistance to the milkshake flowing through that small straw, and that's what's happening here. So if there's something that's causing a small airway, whether it's a foreign body obstruction, a tumor in the airway, a bronchospasm, or a vocal cord issue, there's many things that you could put into this category, but that's going to make it harder for gas to flow and therefore make your muscles work harder to pull gas through that small radius. The elastance, which is the other part here, is think about that as the volume of your lung, how much you can contain. If your lungs are highly elastic, usually your volume's a little bit smaller, right? You're not able to stretch that tissue. You're not able to get as deep of a breath in there. So your brain tells your respiratory muscles, take a deep breath, work harder to get a deep breath because you can't stretch your lungs enough. You're having a hard time getting that volume of gas in there. So you're going to use those accessory muscles to try to pull more gas in there. And so this is going to create a workload that the patient has where we need to take that away from either by resolving the underlying issue or go ahead and using our machines to help assist their ventilation. When you're looking at the right side of this equation here, the resistance part and the flow part, the resistance and the elastance workload is what we're looking at here. Do they have a restrictive issue going on? Do they have an obstructive issue going on? Is there a combined issue where the person that has kyphoscoliosis, which would have high elastance, right, high elastance load because their lung volumes are smaller, has a bronchospasm. So now they have resistance to gas flowing in on top of a smaller volume to begin with. That patient's going to work really hard to breathe. And so that's what we're looking at with the equation of motion, is obstructive disease with resistance, restrictive disease with elastance, or restrictive issues with elastance. That could be pleural effusions as well with elastance. That could be abdomen chest wall issues with elastance, not just the tissue being stiff, right? So when we're looking at these two things, that workload that's put on the patient can be very demanding, and the whole point here is just to be able to get adequate gas exchange for homeostasis. So as we see here, if we don't resolve the underlying issue, then we're going to have to work to assist the patient until that issue can be resolved. So that resistive pressure would usually increase in things like asthma, or one of the things that we could do is look at this also with a ventilator. If I increase the flow or change the flow rate on the ventilator, that's going to change the workload that's going on with the patient. If I increase the flow rate, that should decrease the workload of the patient trying to pull a breath in. So if I make the breath go faster into the patient, that reduces the workload of that patient. So that way they can have their muscles rest and recover while we're taking over their work of breathing. If I decrease that flow rate significantly where the patient is no longer getting the amount of flow that they need, then that's what we're looking at here, where they might be working hard even while on a ventilator. Just because someone's on a ventilator doesn't mean that you're reducing their work of breathing. You need to set your settings on the ventilator to reduce the work of breathing, and you need to monitor your patient, visually inspect your patient for that work of breathing. Yes, we have waveforms we can look for ventilator imposed work of breathing, but also inspect your patient. Are they working hard to breathe on the ventilator, and do you want them doing that? Very rare cases would you want them to be working hard on the ventilator. Other than that, usually we're trying to take that workload away from them. Issues like ARDS and pulmonary fibrosis are things that would increase the elastic workload and make it hard for them to do that. And how do they adapt their breathing? If they can't breathe deep, they'll breathe fast. So they have rapid, shallow breathing. They have very small tidal volumes because the elastic load is very high. So that's what we're looking at here. So simply stated, the equation of motion is looking at how much resistance there is to push the breath in, as well as how hard it is to stretch the lungs. And if either of these are your patient's issues, then we need to work to help resolve those issues sooner than later. So this is a single compartment model of the respiratory system. So here we're looking at the airway opening up here at the very top. We're looking at the resistance to gas blowing in here, and that's what we're looking at here. And if you're already in mechanical ventilation class, you know this is airway resistance, or RAW. And then down here, we're looking at how hard or easy it is to stretch the container, and that would be your compliance, right? That's the volume of your lungs, right? And so when we're looking at these conditions, when we're giving a breath, we're looking at these elastance. Am I having trouble pushing the gas in there? Is there something small with their airways, whether it's a foreign body, there's a mucus plug, there's a bronchospasm, something that's causing that airway resistance to be really high? It's going to make the patient work hard to breathe if they were spontaneously breathing. But also, if they're on the ventilator, we might have to adjust our settings to reduce the patient's workload of breathing, even while they're on the ventilator, to reduce that until we can get the underlying resistance issue solved. The other part here is looking at the elastance, and that's that lung compliance is how we look at that on the respiratory side of things. And so when we're looking at this, we're trying to get rid of the workload of the breath delivery. If I can get rid of the workload of breath delivery, then I'm taking the workload away from the patient's muscles altogether. I'm taking the workload away from their heart. I'm taking the workload away from their body. I'm taking that physiologic workload away from them to let them recover from whatever process they're on the ventilator from. That's the whole point of calling it life support, is we're taking that workload away to support them to live, right? To let their body heal and recover. So here you're going to see a different model here, but this is a way of applying the equation of motion. There is a mode out there called proportional assist ventilation that really looks at the equation of motion in detail, and it looks at the resistance and elastance as a prerequisite. And during breath delivery, volume and flow are measured every 5 milliseconds, so it's super quick. And then we know the elastance, we know the resistance, and we know the pressure total that we're looking at by looking at the equation of motion. That's what that mode does. So what the ventilator does is it adjusts the breath delivery based upon the workload of the patient. So what you do as the respiratory therapist is you set a percent support. So let's say you set the ventilator at 50% support. That means half of the pressure for the ventilator to deliver the breath will be done by the ventilator, and the other half will be done by the patient. So you'll adjust what percentage of work of breathing you want the patient to be doing. So if they're very sick, you could set it to where the patient is only doing 25% of the work of breathing. In a situation where you're trying to wean this patient off the ventilator, you could set it where the ventilator is at 25%, so the patient's doing 75% of the work of breathing. So you can titrate it to let the patient recover, titrate it down to the point where you're getting ready to let them off the ventilator as well. So it's kind of interesting to see that there's even a mode out there that takes this into account. And what they're looking to here is a practical application of how much resistance is there for the gas to be flowing in, how much is there with elastic resistance as well, the elasticity of the chest wall, abdomen, the lung tissue, and it's going to use that to adjust the breath delivery. So it's kind of interesting to see that even with mechanical ventilation, you wouldn't set a rate or a tidal volume in this case. You would set a workload of breathing for the patient. And in this mode too, it would give you a work of breathing bar to show you how hard or easy it is for them to work or breathe. So it's a pretty interesting application. All right, I love pictures, so obviously this is going to be full of pictures. So as we're looking at this is the simply stated slide, as much simply stated as I can put in here. You have two things that we're looking at here. Trans-respiratory pressure is the big picture. This is how much it takes to get gas from here all the way down here, right? So that's everything in there. That's trans-respiratory pressure. Transairway is just to get the gas from here to here, right? Just to get the gas through the conducting zone, through your trachea, your mainstem bronchi, your segmental bronchi, all those things, all the way down to the terminal bronchioles, all the way down. Okay, so that would be things like mucus plugging, that would be things like bronchospasm, that would be things like foreign bodies, all those things that are in the conducting zone that would cause that resistance to go up. And then transthoracic pressure is what we're looking at here. Transthoracic pressure is the ability to get that respiratory zone to expand. So transthoracic pressure is trying to get that expansion. Now, if I have a bunch of pleural effusion that's just pushing in on my lung, then I'm going to have a very high elastance. So my lung compliance is going to be very low because they're inverse of each other. And so my lung compliance is going to get worse and worse, and the patient's going to work harder and harder to breathe because their lung volumes are getting smaller and smaller, and they're trying to work harder and harder to get them to expand, but all that water or that fluid or whatever's in that pleural space is just pushing and pushing and pushing and making it hard for them to expand their lungs, so the patient's going to work hard. Well, that's where the ventilator can come in. The ventilator can take that workload away from the patient until we resolve that pleural effusion issue. So this is a different model. Obviously, I wanted to start at a more basic picture and then work you up to a more advanced picture. And this is the equation of motion down here, right? The ventilator or the muscle, right, is really doing the resistance and elastance part of this. So if someone has a pleural effusion on top of having an asthma attack, you know, heaven forbid, but they're going to have both of these working at the same time, and they're going to be a high chance for respiratory fatigue and failure, and that's where we need to take that workload away from the patient. So transrespiratory pressure, this is everything that was on the previous slide. I just made it look a little bit more complicated here, but ultimately we're looking at how hard is it to get a breath not only through the airways with this trans airway pressure, but also to expand the airways, which is the transthoracic pressure, and all that together is transrespiratory pressure. All right, another picture here. What do we see with a restrictive process? A restrictive process, that's what we're talking about with functional residual capacity back from the PFT world. But with a restrictive process, you're going to have the lungs have a natural tendency to collapse, to go inward, to get smaller, and you're going to have a lower FRC. So if this patient's working hard, when you have a bubble, right, when we're looking at these laws, Laplace's law, especially when we're looking at surface tension and elastic recoil, the smaller it is, the harder it is to maintain its shape and to stay open. So they lose their FRC, they're going to be more prone to atelectasis, they're going to be more prone to having poor gas exchange, whether it's getting CO2 out or oxygen into their bloodstream. They're going to have that proportion of doing that. And so what we can do from our end is to increase our pressure, to increase the FRC. We can give them more support to restore the FRC back to a normal value for that patient. And that's what the ventilator can do. We can give them that CPAP or that PEEP or that mean airway pressure to restore that FRC to a functional level, so that way they're not working as hard to breathe. Because if you're trying to work hard against a small balloon versus a large balloon, it's a lot easier to expand a large balloon even more than to expand a small balloon even a little. So we need to make sure that we can restore that FRC. And some modes are out there where it can help us with this. There's even a ventilator where you can look at the pleural pressure with an esophageal balloon and match that pleural pressure with your PEEP and take and restore that FRC. It's pretty cool. Another thing that we can look at here is the resistance to gas flowing in and out, right? If we have an issue with the gas flowing in or out, especially out because your airways get smaller when you exhale, even though there's cartilaginous outside layer of your respiratory, your conducting zone, you're going to see that there's still a little bit of collapse that happens, not all the way, but a little bit of collapse that happens there. So what if we're trapping gas? What if our lungs are already very narrow airways to begin with our conducting zone? One of the things we can do is increase PEEP on the ventilator or increase the CPAP on the ventilator to stent open those airways, just like someone that has sleep apnea where we give them a CPAP to stent open their throat so that way they can breathe fully during their sleep cycle. Same thing here, we can stent open those airways with CPAP, with PEEP, with mean airway pressure to allow for more complete gas to go in and more complete gas to come out, to stent them open, to reduce that workload because they're trying to work harder to breathe through those zones. And this is the mental image that I was talking about earlier of having a milkshake and trying to drink a coffee straw, use it with a coffee straw. You're going to have to use a lot of workload to drink just that little bit of milkshake. And so that's what we're looking at here. How can we do this? Well, we can make the straw bigger, and that way you don't have to work as hard to drink that milkshake, right? Well, that's what we're doing here. If we give them PEEP, we give them CPAP, we reduce that workload there, then they're going to have a lot easier time to breathe. All right, I have to put normals in here. So compliance and resistance, that's what we're looking at here. Normal compliance in you and I, the spontaneously breathing patients, usually about 50 to 170 mLs per centimeter water. But intubated patients, it's going to be lower, 40 to 50 for males and about 35 to 45 for females. Understand this is because we're no longer using negative pressure to breathe, we're using positive pressure, and gas does not distribute as evenly with positive pressure ventilation as it does with negative pressure ventilation, and therefore compliance changes. So we're going to have those issues there. And also, what's their workload? Is the patient using their muscles actively to do this? And they may have a struggle to actively do that as well because they're fatigued, and so that's going to decrease the amount of negative pressure breathing and the compliance as well. Resistance over here on the other side, for an unintubated patient, 0.6 to 2.4 centimeters of water per liter per second. That's okay, but what we're looking for is traditionally our intubated patients is roughly around 6 centimeters of water per liter per second is around normal. Now understand these are great to know, like know normals, you need to know normals all the time, but understand when you're doing your ventilator assessments with these patients is that you're trending where they're at. Is their raw steadily getting worse and worse each time you go in there to check on them? Is their raw getting better each time you're checking them? Is their compliance getting worse? Is their pleural effusion getting worse? Is their pneumonia getting worse? Or is their compliance improving each time you're seeing them? Because as their lung characteristics change, that will change the ability for us to titrate settings. Sometimes we might have to be more aggressive with our settings by adding more PEEP. Sometimes if their lungs are getting better, we might have to take away PEEP to avoid injury and issues there. So we need to be checking these every time we go and see a patient. Is their compliance changing? Is their resistance changing? So it's good to know normal. But if you already have a patient that has a high raw to begin with, let's say it is a patient that has emphysema, right? Emphysema has a high raw, then are you ever going to get it to that perfect 6 centimeters of water per liter per second? No, but you want to trend these things when you're looking at these patients from assessment to assessment. So what are some clinical conditions that really impact the compliance? Well, a decreased compliance is primarily what you're looking at here. And there's two types of compliance. There's static and dynamic. And I'm going to circle the static compliance here because that is the primary one that we look at with a lot of these patients. This is the one that looks at the health of the respiratory zone. Okay, so if there's atelectasis where the lung units are collapsed, or ARDS where the lungs are filling up with pus and developing hyaline membrane, or pneumothorax where the lungs are severely collapsed because there's air in the pleural space. If the patient has morbid obesity or a lot of secretions that are just hanging out in there like pulmonary edema, things like that, it's going to make it harder for the lungs to stretch. All these things make it harder for the lung to stretch. So think about that as the respiratory zone. It's the health of the respiratory zone. It's the health of the respiratory zone. So static compliance is health of the respiratory zone. Dynamic compliance, it's a different equation. So static compliance uses plateau pressure or a static measurement there. Dynamic compliance does not. It uses your tidal volume over your PIP minus your end expiratory pressure. So it doesn't have a pause in there. So not only does it look at your static characteristics, you're right, how hard it is for the breath to be delivered, but now it's going to include what's going on with the conducting zone. Is there bronchospasm? Is the ET tube kinked? Is the cuff herniated over the end of the tube? Is there an airway obstruction like a mucus plug that's going on? Those are things that can make dynamic compliance worse. Dynamic compliance trending worse with static compliance staying the same is an airway resistance issue. What would cause an increased compliance? Not too many things, but emphysema is one of those that can cause an increase from baseline. And then surfactant replacement therapy that we do in premature babies as well. Usually you'll see their compliance change fairly quick if it is a surfactant deficiency issue. All right. So what if someone has a high airway resistance, but their compliance is perfectly normal? This could happen with COPD. Their compliance could actually be a little high there too, that we were talking about earlier. Depends what level of COPD they have as well. Asthma, high resistance, it's conducting zone thing, right? So here I want you to think about conducting zone, trachea, mainstem bronchi, segmental bronchi, all the way down to the terminal bronchial. So all of those things, that's what we're looking at here. So if there's an issue with this ventilator circuit, they're biting on the tube, secretions, things like that will cause the resistance to increase and make them work harder to breathe even when they're on the ventilator. It can make them work harder to breathe on the ventilator. So we need to adjust our modes as well as treating, not modes, but our settings, as well as treating the underlying cause, of course. But in the meantime, we might need to adjust some settings until their underlying cause. You can't usually fix a bronchospasm right away. We can start treating the underlying cause and then adjust our settings in the meantime until that cause is reversed. Now, what if we have low compliance? And that's typically what we see with a lot of our patients. ARDS, that syndrome that's usually caused by sepsis, but a number of different things can cause it, whether it's direct or indirect ARDS. That's a whole separate video, but direct or indirect ARDS, where the lung tissue just fills up with pus and cellular debris, and there's hyaline membrane formation, and it makes everything stiff. Pneumonia, same thing. There's swelling of the lymph tissue in the respiratory zone. Pulmonary edema, there's a bunch of fluid hanging out in the respiratory zone. Pneumothorax, a squishing of the respiratory zone. Do you hear a common theme here? Yeah, respiratory zone. Right, this is where your gas exchange happens, right? Pleural effusion, squishing of the respiratory zone. Obesity, morbid obesity, pushing of the respiratory zone. Any abdominal compartment injury, anything like that, we're looking at a low compliance. And usually it's an issue with the respiratory zone either being squished or there's an issue with the chest wall abdomen that's squishing it. So whether it's the tissue itself or something from external squishing it, that's what we're seeing here. So why do we care? Well, both of these are going to increase the workload of the patient. If we know which one is increasing the workload of the patient on the ventilator, then we know which one to work with. So would I give bronchodilators for an pleural effusion patient that keeps getting their pleural effusion worse? No, I mean the bronchodilators won't fix the pleural effusion. At least not that I know of, but I can work on what's going on. So if I know it's a compliance issue that's causing this patient to work to breathe, hey, where's the ultrasound? Where's the x-ray? Let's see if there is a pleural effusion going on, and then we can start treating that, and then their workload of breathing decreases. Lower stay on the ventilator, lower stay in the ICU, lower stay in the hospital, hopefully. All those good things come from it. Same thing if I have someone that's wheezing greatly, checking them for pleural effusion is not necessarily going to be the first thing on the list because we're looking at something like a bronchospasm response. And so my intervention needs to be tailored to something for the conducting zone. Same thing with a compliance issue. My intervention usually needs to be tailored to something to deal with the respiratory zone. And that's the value of knowing. You see a patient on a ventilator working hard to breathe. Is there issue with their conducting zone? Is there issue with the respiratory zone? Sometimes both. You can have an asthmatic that's having a pleural effusion or pneumonia, right? You can have that happen where both of these are going on at the same time. But then you know you're going to need an intervention from the conducting zone and an intervention for the respiratory zone. Right, and that's what we're seeing here. The workload from the ventilator, and that's what we see in this very simple diagram. The workload of the ventilator will have to increase to get the gas through the airways and then ultimately expand the chest wall and the diaphragm. We're pushing against all of this. And so that's what we're seeing. The ventilator workload is trying to reduce the patient's workload by pushing the gas in and getting the lungs expanded there and reducing the workload of the diaphragm. So when you see a patient on a ventilator or on non-invasive ventilation, working hard to breathe, we're probably not giving them enough support. So once again, big picture here. I saved this for later on in the presentation, but here you can see we're looking at trans-airway pressure, which is the pressure gradient here between the mouth and getting it down here through the conducting zone. And then we're looking at that. I'll circle it. Trans-airway pressure, pressure at the airway opening versus the pressure in the alveoli. So how much pressure does it take to get from the mouth to your respiratory zone? So this is how much pressure to get through the conducting zone, right? So this would be airway resistance. So I'm just going to put resistance over here, airway resistance. And then down here, we're looking at alveolar and pleural pressure. We're looking at this being lung compliance. So I'll just put a C there for lung compliance. And so those are the two forces we have to overcome when we're breathing. We have to overcome the resistance to gas flowing through our tubes, and we also have to overcome the elasticity of our lungs stretching. All right, so once again, I'm building up the equation a little bit here. So when we're looking at this, the patient response to mechanical ventilation could be something that's helpful to us to adjust to. So if I reduce their elastic workload, what are some things I can do to reduce that elastic workload so that way there's not as much muscle workload of the patient? If I reduce that elastic workload, whether it's mechanical workload, if I give them some pharmacological interventions, maybe there's a reflex that's going on, maybe there's something there that I can adjust to help them have a better expansion of the tissue, whether it's diuretics, if they have edema going on, if they're safe to do that. Those are the things that we can look at here. So when you see a patient working hard on the ventilator, maybe it's not just mechanical adjustments. Sometimes it's something we could recommend pharmacologically. Maybe it's something that we can recommend otherwise to really help clear their airways. If it's a raw issue, maybe we do airway clearance therapy, some sort of airway clearance therapy. I'm not talking about suctioning. I'm talking about actual airway clearance therapy with the vest, with Medeneb, with some sort of device to help clear the secretions. And sometimes that includes pharmacological to help clear the secretions as well, treating what's causing all the secretions. So this is a way to look at this. The ventilation pressure over here, so that you're like, you lost me here, but here you go. Hopefully I'm going to regain you again. So if you're lost, here you go. The amount of pressure it takes to breathe is a sum of how much it takes to expand the lungs as well as how much it takes to get gas through the airways. So how big your tubes are over here, think about the radius of your airways, and then over here think about the volume of your container, your lungs, right? So if I have smaller volumes and I have smaller tubes, I'm going to work really harder to breathe. If I have bigger tubes and bigger volumes, then I'm not going to work as hard to breathe. And that's what we're doing here, is we're trying to take that elastic pressure away from them, that resistance pressure away from them by using our breathing machines until their underlying cause can be treated. All right, so this is something to look at for weaning, and I put something in here on weaning on purpose because when we're trying to take a person off the ventilator, we need to make sure that they can breathe on their own before we take them off. It's kind of a prerequisite type thing to evaluate. And so we need to make sure their primary underlying cause for being on the ventilator is treated. So we need to titrate to minimal support to take that workload away from the patient. Now we're going to give the workload back to the patient to see how they're doing. So we might have to do a sedation reduction or sedation vacation. And then we're going to see how the patient breathes with minimal ventilator support, so we can see how they can breathe with their own respiratory support. If they're still working hard to breathe on their own, then they may not be recovered enough to come off the ventilator. So when these patients are extubated and they're taken off the ventilator, if they're working really hard to breathe, we may have to put them on, or we might be able to extubate them to a device that gives them a little bit of support, but is not as much support as what they had previously. So when we go to wean a patient, we need to take that workload back off the ventilator and put a little bit of it back onto the patient to evaluate if they're ready, if their lungs and their respiratory muscles are recovered, if they're their underlying condition has recovered to the point where they're stable enough to be taken off. All right, so when we do a wean on a patient, this is what we're talking about with spontaneous breathing trial. Usually it's about a 30-minute to 120 minutes. Each hospital may have its own policies and procedures there, but there's different ways to do a wean. And when we're looking at this, there's the T-piece wean, which I will tell you there's for a certain patient population, I loved it for, just a straight CPAP wean, and then there's a pressure support wean. So this is showing how much workload a patient has to do on these types of weans. So if I want the patient to do the least amount of workload for the wean, we're just trying it out, they're on because of respiratory fatigue and failure, using a pressure support mode, very similar to non-invasive, but on the ventilator, is going to give them the most support to relieve any workload that they might be having to do. If I just give them CPAP, but no pressure support, they're getting oxygen, but they're not getting any inspiratory augmentation. In other words, when they take that breath in, the patient's doing more work, right? But they're still getting some positive pressure and some oxygen, but the patient's doing more work. And as we're going this direction, and that's where this arrow is going down there, as we're going this direction to the T-piece, it's giving them oxygen, it's giving them flow, but it really doesn't give them any pressure to support their work of breathing. Well, why would we do this? Why would we try a T-piece wean? Well, one of my famous ideas, well, it's not my idea, but one of my famous things that I loved doing for patients that were hemodynamically unstable to begin with, and then they're stable now, we're looking at extubating these patients, is usually it wasn't their lungs that were the issue, it was the heart. Is their heart stable enough to go without that extra thoracic pressure? So if we take that thoracic pressure away, which is what CPAP and pressure support, all those things do, if we take that away, we can see if their heart's healthy enough to come off the ventilator. Usually their lungs weren't fatigued, it was their heart that was the issue. So on those patients where I wanted to see if their hemodynamics were stable enough to be extubated, I would do a T-piece wean on those patients without all the extra thoracic pressure to really see if the heart is stable enough for that. So we can see that pretty straightforward. As always, follow your hospital's policies and procedure and whatever evidence-based guidelines come out, but this is just showing a diagram of the most amount of support with that pressure support to the least amount of support with that T-piece. Which ones give you the most reduction in work of breathing? So if you have a patient that's working hard in a straight CPAP wean, then maybe you can try pressure support wean with them, right? If you have a patient and they're really concerned that that thoracic pressure is really helping them still be somewhat stable and we don't know how they'll do on the extubate, then try over on that T-piece and see what the care team decides there. All right, so this is an electrical analogy for all you engineers out there. I'm going to try, but don't hold me to any engineering things. But you're working on that, looking at that workload, right? So pressure equals the voltage that's flowing through this, and the current is going to be that flow that's going through there. The charge is how much volume is going through there. So we're seeing the ability for this to happen, how much energy there is to breathe. And this is why some patients will have a big struggle why they're breathing, is that all the extra energy they're using. So I'm pulling that analogy over to the workload of energy, but that's what we're seeing here is they're having to use more energy, more workflow to get that to travel, right? They have to get more energy to do that. All right, so what are some issues that we see here? So when we're looking at the patient, we can also look at hemodynamic, and that's what I was talking about before. When we look at these workload on these patients, sometimes their workload isn't necessarily pulmonary. The workload, they're using their lungs, but they're trying to compensate for the heart. Their heart is failing, and so they're trying to breathe faster and deeper to get their body more oxygen because they're not being able to pump it as efficiently as they once were, or their blood vessels are dilated, or they don't have as much blood volume as they need to. And so those three factors can really make someone work harder to breathe because they can't get the oxygen and the CO2 exchange that they really need. And that's what we're looking at with this picture. The workload of the heart, both the right and the left ventricle, are pretty significant. And so when we take the workload away by increasing something like PEEP, right? By increasing PEEP, not to the point where it's squishing everything so there's no vena cava, but we can reduce the workload of the heart because now we're taking that workload away from the patient. And one of the things that can happen if we have certain waveforms on the ventilator, and we'll talk about that in the future, is that can restrict the blood flowing into the ventricles and reduce the workload of the right ventricular and the left ventricular workload as well. So those are the things that can really help support the heart while the patient's working hard to breathe. Because sometimes, like I said, even though their lungs are working hard to breathe, maybe it's not a lasting or compliance issue or a raw issue, but maybe instead it's a cardiac issue. And if it's a cardiac issue, how can I use the ventilator settings to reduce that workload, right? To reduce that workload, because I don't want their lungs starting to fail on top of their heart already being in failure. So I need to support that workload. And that's where using things like mean airway pressure or PEEP can be really helpful on helping your hemodynamic patients. So if it's a heart failure patient where it's as far as that ventricle is getting overloaded and it's not snapping back by Frank Starling's law, right? Then what we can do is increase the PEEP or the mean airway pressure to reduce the volume of blood going through there to reduce the workload of that left ventricle. Or things like if their PEEP is too high and we're reducing that blood flow too much, then we might need to reduce the PEEP so that way there's more blood to go through there. But we can see how healthy the heart is when we do that. Oh heavens, look at this slide. All right, so when we're looking at this is looking at the power or the energy it takes to breathe. So there's two ways to deliver a breath. There's volume control over here on this left side and pressure control over here on this left side. And so there's two ways. Volume control ventilation is typical standard for most patients currently, as it has a very advantage of a stable blood gas. We know their minute ventilation. We set a rate, we set a tidal volume. Can they breathe above that? Absolutely. But the blood gas is very predictable, very stable because they have the same minute ventilation. Their alveolar minute ventilation can change a little bit, but overall it's fairly stable. So the blood gases are fairly stable. You also avoid volume trauma, where the lungs overstretch and cause extra issues there. So there's volume ventilation. The next one below that is PCV, pressure control ventilation. This one's a little different. This one, you're using pressure to deliver the breath, so you're not exceeding a certain pressure, so you're avoiding barotrauma. And so you allow for that flow rate to be free floating. So the patient, if they require very high fast flow rate in pressure control ventilation, they can take it if they need it. If they want to do a slower flow rate, they can also do a slower flow rate. So pressure control has the advantage of avoiding barotrauma, and volume control has the advantage of avoiding volutrauma. And so what we're looking at traditionally is volume control ventilation for most patients out there, unless their plateau pressures, or in other words, or the pressure it takes to deliver the breath is too high where it could cause barotrauma, then we'd have to go to a mode that controls the pressure, which is pressure control, to help avoid that barotrauma. Now, could they hypoventilate with the pressure control? Absolutely. They could hypoventilate with that mode, but if it avoids further lung injury, then we might have to do that with permissive hypercapnia ventilation. So what influence our cardiopulmonary interactions during mechanical ventilation? There's two things, the patient and the machine. And you got to be good at both of these. The big thing is always look at your patient. That's part of your patient inspection, is part of your patient assessment. So make sure you're looking at their hemodynamics. Make sure you're looking at therapeutic interventions to treat underlying cause. Don't just treat the machine, treat the patient. Where are we at with their underlying cause? That's what we need to be looking at. Over here at the ventilator side, is there changes that we can make with setting our PEEP, setting our tidal volume, our respiratory rate, our inspiratory time, how much we're doing with the breath, our flow, how fast we're delivering the breath, or how slow we're doing this. So we need to see that, as well as how's our patient responding to what we're giving them. What's their effort with this? What mode, is there a different mode that they might do better in? Did I give them a sensitive enough trigger to trigger a breath on their own if they want to do an extra trigger? If they want to pull that in, is it sensitive enough to let them do that? Because if I don't, let it be sensitive enough, they're going to be working really hard to trigger their breath. And now you're defeating yourself because you want to take away the worker breathing, and now they're working harder because your setting is not appropriate. Sedation, patient comfort can be things to look at here. Probably this is going to be a care team discussion. You're not going to be going in and adjusting any IVs or anything like that. But these are the factors that really go into it. Are we looking at our patient and the things we can do from the patient side? And are we looking at the mechanical ventilation factors and how are patients responding to those? We need to look at both of these to really reduce this worker breathing. All right. So what about auto PEEP? Auto PEEP is a big thing. Auto PEEP in volume control and auto PEEP during pressure control ventilation. We're going to see that with auto PEEP, the patient's going to work hard. So if auto PEEP is not addressed, hemodynamic compromise will ultimately occur, and they'll go into a respiratory acidosis, because, especially in pressure control, or alveolar overdistension during volume control. And so we're seeing these things where if the patient has air trapping, if they have auto PEEP, they have intrinsic PEEP is the other word that's out there, sneaky PEEP, occult PEEP, there's a lot of different terms that have been out there. But any of these things are going to increase the workload of breathing, right? So we see whether they're in pressure control ventilation or volume control ventilation, we're going to have these issues where it can cause lung damage, lung trauma, and worker breathing. So pay attention. If your patient does have auto PEEP or intrinsic PEEP, then we need to look at, okay, what are some causes for this? Is there something I can do on the ventilator end? Can I decrease their inspiratory time if they're in pressure control? Can I increase their flow rate to decrease their inspiratory time if they're in volume control? Can I decrease the respiratory rate to allow for a longer expiratory time constant? What are some causes? Why are they auto PEEPing, right? Sometimes it might be increasing your set PEEP on the ventilator to stent open the airways. That way there's less gas being trapped in there. More gas can escape as we stent open the airways. So we need to look at what's causing this, because in both of these situations, if your patient's air trapping, whether they're in volume control or pressure control, they're going to work harder to breathe, and it can cause some damage as well. So what makes this so hard? Here's the big picture of this whole thing. It's the energy, right? When a patient's working hard to breathe, whether they're spontaneously breathing or on the ventilator, it takes a lot of energy to breathe. And so what we need to do as respiratory therapists and as the care teams is have discussions on what can we do to really relieve their worker breathing. Can it be something as simple as giving them oxygen if they're hypoxic and they're less tachypnic and it just relieves their hypoxemia? Absolutely. It could be something like putting them on oxygen, low flow or high flow oxygen. But in the case where they have issues like pleural effusions or they're developing a pneumonia where their elastance is increasing, compliance is decreasing, where their elastance is increasing, then maybe we need to do things that help that situation. Or maybe they're having a bronchospasm, maybe they're having mucus plugs, and it's the resistance to breathing that's the issue that's causing them to work harder. We need to treat those things. But in the meantime, is there interventions we can do that are mechanical as well that could reduce that workload to avoid them going into further fatigue or possibly respiratory failure? So hopefully you got something out of this. Thank you.